Okay, so I'm going to point out to you guys the important things to really look at here. So this is going to talk about what causes bleeding in pregnancy based on the mom's trimester. So there are a couple of bleeding that is common only in the first trimester, in the second trimester, and the third trimester. Okay, so in test questions, you want to pay attention to how many weeks that gestation is, because then that will give you a clue as to what kind of bleeding the mom is having based on the gestational age. Okay, so let's start with the first trimester. Let's make sure. So there's two main causes of bleeding in the first trimester, which is abortion and ectopic pregnancy. Okay, so abortion and ectopic pregnancy. Let's talk about abortion first. I've mentioned to you guys that in OB, when we say abortion, we don't just mean an elective abortion. Any type of loss of pregnancy before 20 weeks is an abortion. Okay. So who's at risk for that? Moms who have like chronic maternal infections, if they're older than 35 or 35 and older, if they have type 1 diabetes, any type of the baby having chromosomal abnormality. Chromosomal abnormality, for example, like Down syndrome is a chromosomal abnormality, right? Trisomy 21. Then that could be at risk for that. And then if the mom's cervix dilates sooner than it should, if she has like a soft cervix, or sometimes we say a short cervix. So when we go into preterm labor, we'll talk about that. If mom is malnourished, if mom has had, this is pretty obvious, any trauma injury, any placental anomaly, sometimes the placenta will calcify. So calcification means the placenta hardens sooner than it should. So that kind of is similar to placental aging, which kind of outside of this is why by 40 weeks, we want that baby delivered, because if not, the placenta also gets older. And the older the placenta gets, the harder it becomes. So then less part of the placenta is able to perfuse to the baby. So then that risks the baby not getting enough perfusion. Okay. So in here where it says fetal or placental anomaly, that could be part of the placental anomaly. And then we'll talk about the other placental anomalies also that could cause that. SUD, substance use disorder, or antiphospholipid syndrome of the mom. So in this syndrome, this is an autoimmune disease wherein the mom will get a lot of blood clots. So then all of those could lead to an abortion, and there's different kinds of abortion. Spontaneous is what we know as miscarriage. Okay, so when you're talking to a patient, please don't tell them how many abortions have you had, because that could sometimes, sound offensive, right? So we only use the word abortion for miscarriage among healthcare professionals when we're talking about it, or in the medical records. When we're talking to the patient, you do want to say how many miscarriages, okay, if you've had any miscarriages. So in a spontaneous abortion could be incomplete, complete, or missed. When we say a spontaneous abortion is incomplete, basically some parts of the uterus content came out, but not all. Okay, so maybe like the amnion is still there, or maybe like the fetus is still there, but then parts of the placenta has already come out, so that's an incomplete. Complete is just everything came out. Missed is when the fetus is already, the embryo is already non-viable. So the embryo had already died, but the mom didn't know it. And the embryo stays in the uterus for about 6 weeks. Okay. How would this translate? So the HCG will start to go down, right? And eventually, again, we're talking about bleeding here. So eventually the mom will start to trickle blood, so that's why we say as a prenatal teaching, you always want to look for any spotting or bleeding, right? So if you have any spotting or bleeding, you come back to the clinic, or if it's, if you're worried about it and it's before 20 weeks, first trimester, you go to the ER. Okay. So 20 weeks, so first trimester, they don't go to the L&D. If they have a problem, they go to the ER. After 20 weeks, any problem, they don't go to the ER, they go straight to L&D. Okay. Because they could get monitored there. So other types of abortion could be a threatened abortion or an inevitable abortion. So a threatened abortion basically has not happened yet, but there's a high chance that it will happen if we don't do something about it. Okay. And there's other factors. So when we look at premature contractions and delivery, we'll talk more about that. Okay. Inevitable, the cervix may be short, the cervix may be dilated already, or there could have been some kind of trauma that you just know there's no other way around it. You can't save this baby anymore. So that's abortion. Ectopic pregnancy is when the embryo develops in the fallopian tube where it does develop first, right? But within 3 days, remember, within 72 hours after the sperm and the egg meet and form the zygote in the fallopian tube, it should go down to the uterus to implant, right? But if there's problem with the fallopian tube, then that embryo can go down. So then it gets stuck there. So can you think of some issues that might contribute to that? Well, when would the zygote not be able to come down? How is it that a sperm is able to go into the fallopian tube but not be able to go back into the uterine wall? So fibroids will cause problems with implantation, right? So if there's a fibroid in a certain area, so then the embryo will not be able to implant there, but it will go down to the uterus. What else? Endometriosis, possibly if there's scarring in the fallopian tube. Okay, so here's a few. So if this mom has had frequent STI or currently has an STI, and STIs lead to PIDs, right? So sexually transmitted infections will lead to pelvic inflammatory disease in females. Pelvic inflammatory disease is basically the inflammation of the whole pelvic area, cervix, uterus, fallopian tube. All those will become very, very infected. And so then there's scarring after that, right? And so imagine if the fallopian tube is scarred inside. So then there might be a tiny room for sperm to, kind of go through. But then once the egg and the sperm develops, and now we have this zygote that's bigger, right? Now it gets stuck. You can go back down. So then it gets stuck in there. Any type of assisted reproductive technology, again, just because, when they do procedures, there could be scarring inside the fallopian tube, tubal ligation, tubal surgery. So sometimes, have you ever heard of saying, I had my tubes tied, right? Because they literally just tie the fallopian tube, not cut the fallopian tube. So if they tie the fallopian tube, but then it's not tight enough, right? So then the sperm is still able to go through, but then the space is not big enough for the whole embryo to go down. Then it gets stuck there. IUD, intrauterine device. Anybody know what an IUD is? Okay, so you know how big an IUD is? Yeah, really tiny, about this, right? So it looks like a little T. So, so let's say this is your uterus. That's a wonky uterus, that's okay. And then here's your fallopian tube. So an IUD will be inserted, and the purpose of the IUD, it's gonna look like a little T like that, right? Is to block the opening to the fallopian tube. Okay? And then it'll have like a little string in the vaginal canal, right? Here's your cervix right here. So then it's inserted there, it blocks this area right here. But sometimes this IUD shifts. So imagine the IUD being like this. Right? So now there's an opening there. Okay? But maybe it's just a small opening, maybe a small opening like that, right? So again, big enough for the sperm to go through, but too small for the embryo to go down.
What are those chances?
I don't know statistically, but there's a chance. I mean, there's even babies that have been born with the IUD attached. So yeah, so IUD that could happen. That's why you have to check with ultrasound. That's the only way that you can tell if it's properly placed. Because if you feel right, you just feel, oh yeah, the string's there. Yeah, it's all good. No, what if it's like that? So anyway, so that can cause ectopic pregnancy. So what are the signs? Let's go back to abortion first. So what are the signs that this mom is having an abortion? There's going to be abdominal cramping. There could be a rupture of the membrane already that had caused a dilation of the cervix. They'll have a fever. If there's a lot of bleeding, there will be signs of hypovolemia. And the first sign of hypovolemia is increased heart rate, followed by the low blood pressure, hypotension. Okay, how high? Greater than 100 of heart rate, or 110 really, and systolic of 90 or less. Okay, so those are signs of your hypovolemia. By that time, you'll know because there will be a lot of bleeding. Okay, and there should not be any bleeding in the first trimester. So there's this thing that people say, oh yeah, you get a little spotting during implantation, right? You won't even know you're pregnant during implantation, right? Because that's the first 3 days. Okay. So there should not be any spotting. And then with ectopic pregnancy, what makes us different from the bleeding from abortion is the pain. So in an abortion, the cramping is very diffuse. It's very generalized. Right. That's okay. In ectopic pregnancy, it's unilateral. Only on one side, right? Because not both sides are blocked, right? There's only going to be the embryo on one side. Okay. So whichever side is painful, crampy during pregnancy in the first trimester, and then they have trickling of blood, ectopic pregnancy is your suspicion. Yeah.
Like when you're having, how long does it last?
The what? Pain?
Yeah, the stabbing.
For as long as the baby's there. It will get worse and worse until you get worse, meaning your fallopian tube ruptures, or you get sepsis, or you get hypovolemia, right? Because the baby is going to keep growing in there to a certain extent, right? Until it gets so big. Well, now you got rupture of that fallopian tube. Then what happens after that? You get peritonitis, you get sepsis. Okay. And that's why we, again, teaching wise, they need to go to the ER if this is happening. As far as bleeding, it should be kind of darker red because it's coming from the fallopian tube, so it's a little higher up. as opposed to if the bleeding is coming from somewhere close to the cervical area or the vaginal area, it will be more bright red. Okay. So if the blood is bright red, that likely is because it already has ruptured. The fallopian tube has ruptured. And so other symptoms that the mom might experience is the risk of peritonitis. So how do we know? Peritonitis, I want you to associate with a hard, board-like, rigid abdomen. Okay, so that's one. Hard, board-like, rigid abdomen, even outside of OB, okay, in med-surg. When you hear that the abdomen is hard, board-like, rigid, you're thinking peritonitis, okay? When there's guarding, you're thinking peritonitis. So guarding, it's an involuntary muscle guarding. What that means is that when you palpate the person's belly, it hardens, okay? Because your own muscle is protecting you from being injured further. So then it hardens the muscles at the top, okay? So this is not guarding. The patient saying, no, don't touch me, that's not guarding, okay? Involuntary guarding is the muscles hardening. And rebound tenderness. So those keywords will tell you there's something going on in the abdomen, that there's an inflammation going on. But other symptoms, the mom may have referred shoulder pain. So this is kind of good to know because it's not a classic presentation, right, of an ectopic pregnancy. But if your mom is having bleeding and unilateral pain, right, on one side of either the right or lower or left lower quadrant, and now is also having pain in the shoulder, okay, referred shoulder pain in general in a pregnant woman could be cholecystitis, right? We talked about before. Did we talk about the 4Fs already?
Oh, yes, that was another.
Oh, that was a recap. For cholecystitis or this ectopic pregnancy, okay, because of the irritation of the diaphragm, and the phrenic nerve is in there, and that's what's causing the shoulder pain in ectopic pregnancy. Okay, so that's first trimester. What do we do? For an incomplete abortion, we're gonna do either a D&C or a DNE. DNC is dilatation and curettage. That was, or dilation and curettage. And then DNE is dilatation and evacuation. Okay, what's the difference between the two? A curette is like this instrument that has like a little spoon looking thing at the end of it. Any type of instrument with a long handle and has a little spoon at the end of it is called a curette. You can use that in your ear, right? Little tiny curettes. This is a big curette, metal or instrument curette, okay, that goes in through the vaginal canal, through the cervix, going into the uterus, scraping the content of the endometrial lining. That's the curettage part, okay? General anesthesia, obviously, right? Yeah, but it's dilation and curettage because first you gotta dilate the cervix so you could get in there, okay? What do we use to dilate the cervix? Prostaglandin, okay? And then you can give oxytocin as well to help contract the uterus, to help expel what's in there. But oxytocin also helps dilate the cervix. So D and E, they're gonna go beyond just scraping. They might suction the content inside. But if you think about this, someone who's had D&C or D&E before, and now they're pregnant again, they could have a higher chance of abortion also, right? Because of implantation issues, scarring issues in there. But that's what we're gonna do for abortion. For an ectopic pregnancy, first they have to find out whether or not the pregnancy is still intact and that there's no rupture. If the embryo is still there, they may just give a medication. So a couple of medications that they'll give is methotrexate and again, prostaglandin. So the methotrexate, that's a chemo drug, right? I don't know if you've heard of it before. So this is part of a chemo drug. This is a folate antagonist, okay? And what it's gonna do is it's literally gonna kill the embryo, right? Because it's gonna antagonize the folate, ceasing the life of the embryo. Important nursing consideration, the mom needs to stop the folic acid. Okay, why? Because it's a folate antagonist. So then if the mom has folate in their system, so what is the medication going to antagonize? That folate, not the embryo. So then the efficacy of the medication will be decreased. Make sense? Okay, so methotrexate, no folic acid. And then you give the prostaglandin for what purpose again? So you open the cervix and evacuate the content of the fallopian tube in the uterus, okay? Prostaglandin is the same as misoprostol. That again is used either for abortion or in situations like this for ectopic pregnancy. Now, if we're beyond this, right? If we're beyond that, or maybe the baby is too big for some reason, has already gone, you know, longer than maybe 8 weeks, then they can do a salpingostomy or a self-injectomy. So self-injectomy is basically when they cut the fallopian tube and then they remove the embryo from there. And then they sew it back together. Okay. Self-injectomy is when they have to remove this entire fallopian tube because you can't salvage it anymore. Maybe it has ruptured already. Okay. Any question about first trimester bleed? Only two, right? Abortion and ectopic pregnancy. Okay. Moving on to second trimester. So the main cause of bleeding in the second trimester is due to a gestational trophoblastic disease. You guys remember what a trophoblast is? What is a trophoblast? It becomes a placenta, right? So in this situation here, there's a problem in the way that the trophoblast developed. And so therefore, there's a problem in the way that the placenta develops, okay? There's two kinds. It's either that there really was no placenta at all, and it's all just cancerous trophoblastic cells, okay? So a neoplasm of the trophoblast is called a choriocarcinoma. Because the trophoblast releases what again? HCG, right? So the HCG will be positive, right? What sign of pregnancy is that again? Probable. Good job with the labs, right? So then the mom may think, oh my gosh, I'm pregnant. My, you know, my UPT, my urine pregnancy test is positive, right? It could be this. They won't know until later on, unless they do an ultrasound. So the choriocarcinoma basically is a cancer that will just spread to the lungs, you know, the kidneys, the bladder, the brain, the liver. No baby there whatsoever. Just cancer cells from a trophoblast. Okay. Now, more commonly, however, than that is what we call an H-mole. So in this one here, there was some placenta that did develop from the trophoblast, but it's actually more abnormal placenta than the baby, than the fetus. Okay, so this is called a hydatidiform mole. So an H mole, there's two kinds, a complete or a partial H mole. So how does this happen? How does this develop? In a complete H mole, for whatever reason, there's 46 of the paternal chromosome that enters the mom's fallopian tube, and then she has an empty egg. So it's there's a corpus luteum, no egg inside. Okay, so then it's all just paternal hormones, right? You can't have a baby that way, right? So then what happens is it's just this mold, this hydatidiform mold, the trophoblasts, that continues to grow and grow and grow and grow as if she's pregnant. And her HCG is high, her belly is getting big. You're like, oh, congratulations, she's pregnant. No, it's unfortunately just an H mole. I'll show you how it looks in a minute. Okay. Now a partial, there's 69 chromosomes. So there's one egg, 2 sperm cells. Okay. So then you'll have some type of embryo in there. Okay. It may have some fetal parts, but there's also a hydatif, I can't say that, H mole that is with it. So before we go back, if we go into the signs and symptoms, I mentioned to you guys that this is due to HCG, but this is going to be an excessive amount of HCG because there's an excessive amount of trophoblast, right? So again, another, if mom is vomiting, what kind of sign of pregnancy is that? Presumptive, right? So she's vomiting, her HCG is positive, her abdomen is getting big, right? So we got a lot of presumptive and probable signs, no positive sign of pregnancy, right? So this could lead to hyperemesis gravidarum because of the increase in HCG. And statistically, if the mom had a complete H mole, that could develop into cancer, the choriocarcinoma. Okay, with the partial one, that could, there's a 6% chance that that will develop into cancer. So what are the signs? Again, there will be bleeding, right? So because it's going to start to trickle out. Bleeding with both. There could be preeclampsia before 24 weeks because of the increase in the HCG that could cause hypertension in the mom. And so for complete, this is a key word, an excessively large uterus. Okay, larger than a normal pregnancy. Okay, so, you know, like, you know how people say, oh, do you have twins? You know, are you having twins? It's kind of like that because it's larger than what it should be. As opposed to partial would be either a small or kind of normal size uterus. Okay. Here. Let me switch over to my other map just so you could see how that looks. So here's a complete H mole versus a partial H mole. So just trophoblasts, no baby. Here's a little fetus here. Do you think this fetus is going to survive? This fetus might not even have all parts, right? There might be congenital anomalies on this fetus. So this is going to be a lost pregnancy as well. But there's the H mole along with this. Because HCGs, so remember, in order for us to confirm pregnancy, right, and confirm that this is positive pregnancy, we do the ultrasound, FHR. So imagine having a large belly with no FHR, right? So you got probable signs, but no positive sign. Then they're like, let's do an ultrasound. Let's visualize and see what's going on. Then they'll find this. Yeah, I mean, they will do a biopsy to see if it's cancerous, right? Because it could be just, again, the choriocarcinoma. Okay, so then what are we gonna do for second trimester, second trimester bleeding? They're gonna do that D&E, right? Suction and curettage. Now, if mom is negative, Rh negative, even though this is not a true pregnancy, she still should get RhoGAM. Okay, because there may still be some RH positive content, especially in partial, right? There, because there's a fetus in there. There's a chance that that fetus could be RH positive, and once they evacuate this HMO, and there's mixture of mom's blood and the blood from here, the mom could still develop antibodies. So, you know, even though it's an HMO, mom still gets her RhoGAM. Okay. That way, when she has her actual pregnancy later on, that baby doesn't get harmed by her RH negative blood. Okay. So she'll get a RhoGAM after the surgery. And this is important. There's test questions about this. So you want this mom to follow up every week for 3 weeks after the surgery and check her HCG. Okay. After that, it's going to be monthly for the 6 months and then in a year. So basically for an entire year after this happens, this mom is still going to get monitored to make sure that her HCG is not going up. Why? Nothing remaining. Well, nothing should remain because we're going to do surgery, right? But what could happen? It's kind of related to that. Not that it remains, but it grows back again. Because especially in the choriocarcinoma, right? So we're monitoring for cancer. We're monitoring for HCG increase that could be from an HMO. Well, I wouldn't say restrict from having sexual intercourse, but yeah. I mean, that would be the greatest contraception of all, but you know, I'm not in the United States. That's not going to work. But so yeah. So definitely have to have contraception that is reliable, and monitor for a year. No, the RhoGAM.
Like next time she gets pregnant.
Correct. Yeah. No, the RhoGAM is to prevent an RH incompatibility that could kill an actual fetus the next time she gets pregnant. Because when she's RH negative, she could develop, and the babies are, and the HMO is RH positive, she could develop RH negative, RH positive antibodies after surgery because of the exchange of blood. Okay. All right. You guys are good with second trimester? Only one cause, right? HMO of bleeding. Third trimester, these are the two main ones, which is placenta previa and abruptio placenta. So we kind of had talked about abruptio placenta yesterday, so I'll elaborate a little bit more now. So what's the difference between these two? Those who've been to SimLab, I demonstrated this to you guys, right, if you recall. So placenta previa, the problem is the placenta itself implanted low. It's supposed to implant at the top of the fundus. Oh, I don't have a picture of like here. This is a correct implantation of the placenta, right? It's at the fundus. Now, if this mom had again PID, STI, endometriosis, fibroids, any type of scarring in this area, then as this embryo is going down, right, it's gonna go, okay, I can't implant there, I can't implant there, there's scarring, there's scarring, there's scarring. Okay, I'm gonna implant here, right? And so then it leads to either a low-lying placenta, marginal, partial, or complete placenta previa, okay? So it's classified based on how much it covers the cervix. So complete placenta previa completely covers the cervix. No chance whatsoever of a vaginal birth. In a low-lying placenta, possibly, right? Because it's not actually covering the cervix, it's just really low, okay? And there's a greater chance of cord compression also, right? Because the baby, as the baby grows, by gravity, the baby's like leaning on the placenta and the cord, okay? Maybe a cause of fetal demise, okay? So because especially in these three here, because they're right there by the cervix. There could be like trickling of blood. Here, there could be a lot more blood. So we kind of had talked about who's at risk and how this would implant low. Signs and symptoms wise, so I have some comparison here, but I'll elaborate on this further in a bit. Let's go to placenta abruptio first. So in abrupt placenta, so you hear me kind of interchanging the words, placenta abruptio, abruptio placenta, they're the same. The problem is the placenta starts to detach from the endometrium wall, okay? And as I mentioned to you guys, what is the most common cause of placenta abruptio? That's a test question. Hypertension, okay, or hypertensive disorders in pregnancy. Technically preeclampsia, but preeclampsia is hypertension, right? And then other causes of that are stimulants, either illicit stimulants or, you know, nicotine. I don't know, maybe mom is really stressed out or overworking and drinks Monster. I don't know. You know, just a 5-hour energy drink. So that could cause vasoconstriction, causing the hypertension, preeclampsia. External trauma, MVA, right? Motor vehicular accident. Domestic violence, falls. Okay, we've had like patients at Providence where mom had fallen like the flight of stairs. And so obviously you hear fall, you're thinking, oops, abruptio, let's check for bleeding, right? Again, I'll differentiate what the symptoms are that differentiates this from placenta previa. Premature rupture of membranes, PROM, premature rupture of membranes. Because that rupture may have been so strong that it pulls the placenta off of the wall, okay? Multifetus, maybe the twins or triplets or Octomom, those of you who are old enough to remember Octomom, it pulls on the wall of the uterus, right? So it could tear the placenta. Or unfortunately, if they've had a history of abruptio before, they likely could have abruptio again. So again, how do we differentiate the two? So this table kind of looks at some of the characteristic that differentiates them. But let's talk about pain here. So in placenta previa, is anything tearing? No, right? So there's no pain. So placenta previa is painless. Placenta abruptio, where the placenta is tearing from the wall of the uterus, then there will be severe pain. Okay, so abdominal pain in abruptio, no pain in previa. As far as bleeding, so the bleeding for previa, what color do you think? I mean, not what color, but what shade of red? Bright red. Why? It's fresh. It's right at the opening, right? So then abruptio will be more dark red because it's coming from higher up. Okay. So bright red blood, previa, dark blood, abruptio. Yeah. And then which one do you think may present with a rigid abdomen? Abruptio. Right? Again, there's nothing wrong with previa as far as the implantation or the placenta coming off of the wall of the uterus, right? It's just implanted low. So there really is no other symptom for the mom except the bleeding. Does that make sense? Right? We're hoping the baby's still okay. That's what we're going to do with fetal monitoring, right? So intervention wise, this is a test. Yeah. The fundus is always at the top. The top of the uterus is called the fundus.
No, but the length of
the length.
like, when they're measuring,
Are you talking about fundal height?
Yeah, there you go.
Fundal height is measured more based on the gestational age. And that after 20 weeks, that coincides with the length of the baby. But I guess I think you're saying that maybe statistically there's a higher chance that a premature, I mean, a placenta previa will result in a longer uterus. Is that what you're saying? I don't know that, but if the textbook says that, then there's probably research that has shown that. But I don't know off the top of my head. I wouldn't, for test taking purposes though, I probably wouldn't think about that as far as the signs and symptoms that would define each one. So no vaginal exams, okay? So in a test question, if you see what trimester would this mom be? Third trimester, and it says bright red bleeding, or it will say like history of placenta previa or marginal placenta or partial previa. And they ask you, okay, which intervention will the nurse question, or or will be contraindicated, right? So we don't want to do an vag exam, nothing intravaginally, because we could cause more bleeding, right? This mom, depending on how bad the previa is, she may be able to carry the pregnancy to term. Okay, so for example, in a marginal or a partial previa, if the baby is growing okay, she might just need to be on bed rest for the rest of her pregnancy. And along with that, she may or may not have bathroom privileges. And along with that, she may need to be on Trendelenburg, right? Because we don't want the baby leaning on the placenta, right? And causing cord compression and causing its own decrease in perfusion, okay? So kind of thinking forward to postpartum, when you're taking care of this mom who's been on bed rest for like maybe this is third trimester, so hopefully not too long, right? Maybe just a month or a couple of months. Then what is she at risk for if she's been on bed rest for this long? Flats, DVT, postpartum. Okay, so these are the moms that are high risk for that. Okay, definitely 10. The kick count is extremely important, right? 10 and 2, because of the risk. Okay, and then for a ruptured placenta, this is a medical emergency. Okay. Definitely we want to try and save both the mom and the baby, right? That's why they're going to do an emergency C-section. If the bleeding is very bad, then they might need to do a blood transfusion, especially if the hemoglobin is 7 or less. So most hospitals go by that guideline, 7 or less, and then symptomatic. Okay, some 8, but that's a little bit more conservative. Oxygen, and again, fetal monitoring. Okay, but the main thing is that this is a medical emergency. They need to evacuate the infant, the fetus out of there, and control the bleeding. So these are the 2 most important ones that commonly you'll be asked. These 2 are kind of nice to know. At your level, not so much a need to know, but we'll talk about them. So these are other 2 placental problems. So cause of bleeding in the 3rd trimester. So a vasoprevia or a placenta accreta spectrum. As a matter of fact, I had a student who had a patient with the placenta accreta spectrum. I'll talk about that more in a minute. So vasoprevia, basically what we're saying, those of you who've been to SIM, remember me saying that when we inspect the placenta and we inspect the shiny side, which side is that again? The Schultz, and that's the baby side, right? We want to make sure that the umbilical cord is stemming right from the middle, right? If it's not, then it could be a vasoprevia, okay? Or it could be a velamentous cord. So what does that mean? So look closely here, it is in the middle, right? Here it's not. So then the cord, not only is it not stemming from the middle of the placenta, there's no Wharton jelly here. So Wharton jelly is this covering of the vessels, right? It didn't develop here. So you have exposed blood vessels here, right? And if you have that, greater chance of cord compression, yeah? Because there's nothing that's protecting the cord. Same with, so these are both filamentous cord. Okay, this is obviously a lot worse than this one. Okay. Yeah, so this is how they kind of look. So here it's supposed to be here, right? It's not, it's kind of off there on the side. Here, I can't even tell what's in here. Oops. There's a cord. See, this is an exposed blood vessel here. You see it? Yeah, no, this is the Wharton's jelly, right? The yellow covering, nothing here. That's an ugly looking placenta too. Okay, and then, so that's a vasa previa. And then here in the placenta accreta spectrum, so basically what this means is that the placenta, instead of just implanting into the kind of more shallower surface of the uterus, if you will, right, into the stratum basalis of the endometrium, it implanted deeper. Okay, so kind of like you think of a plant where the roots had grown so deep, like, you know, that it's like infiltrating sewer pipes or whatever, right? So these are the different kinds. So you have a percreta, an increta, and an accreta. The less damaging one is accreta, because it just goes just a little bit deeper into the myometrium, right? So accreta and then increta and then percreta goes all the way through, even to the perimetrium. Okay, what's the danger there? No, the opposite of abruption. It's not going anywhere because it's embedded really deep, right? It's the opposite of abruption. It won't come out. Yeah. So also, how much perfusion is this bringing to the baby? We don't know, right? But postpartum, I mean, not postpartum, but during delivery, can you just pull the placenta out? You can't. Okay, then have to take the uterus out. So they deliver the baby and then they do a hysterectomy. You can't, you know, I mean, how are you going to get that out, especially if it's percreta? Genetic. Yeah, there's a genetic factor to it. Apart from that, I don't know. A lot of these guys is like, you know, if you have like an immediate family member who's been prone to this, then you're likely going to be prone to that also. Yeah, first degree. Yeah, definitely first degree. Yeah. So they obviously, if this mom is getting prenatal care, they would notice in advance, right? So then they will prepare the mom mentally, the family mentally, that, okay, once it's time, here's a consent for hysterectomy, because after you deliver the baby, you know, maybe they'll do just a C-section because, you know, it's a surgery anyway, right? You deliver the baby, do a C-section, take the baby out, and take the uterus out. But you know, we live in the modern days where there's other ways of having a child.